All right, thank you so much. Welcome to another episode of the Love, Hope, Lyme podcast. My name is Fred Diamond. Of course, I'm the author of Love, Hope, Lyme, with family members, partners, and friends who love a chronic Lyme survivor. Need to know if you're watching the show on YouTube, thank you so much. Go up, give us a thumbs up, leave a comment, and we'll get back to you. We get a lot of comments, Dr. Bransfield, on the shows that we post on YouTube. If you're listening on Apple Podcasts or Spotify, particularly Apple Podcasts, go up, give us a 5-star review. We would greatly appreciate that as well. I want to let people know that my book, Love, Hope, Lyme, What Family Members, Partners, and Friends Who Love a Chronic Lyme Survivor, is available on Amazon. Also, Dr. Bransfield, I made the PDF of the book free for chronic Lyme survivors. I've given out well over 2,000. So if you're a chronic Lyme survivor, you want to get the PDF, reach out to me on Facebook or LinkedIn. And Dr. Bransfield, a lot of people have ordered multiple books to send to family members. Reach out to me again via Facebook or LinkedIn, and we'll get them to you. I guess I do need to say that even though I'm talking to the foremost psychiatrist in the Lyme world, that this show does not provide specific medical advice to our listeners. We strongly recommend that you seek personalized medical treatment as needed. But I'm very excited to be talking today with Dr. Robert Bransfield. And Dr. Bransfield, as I was doing my research for Love, Hope, Lyme, and as I published the book, and since then, I've met you've met obviously more people than me. I've met thousands of Lyme survivors, and the psychiatric and psychological aspects of the disease, as you know, are just debilitating in many cases. Mm-hmm. And I really appreciate your comment on the show. I have some very specific questions for you. I'm very much interested in your thoughts on some of this. And a lot of people are aware of you. So I just want to acknowledge you for your place in this world and for all the good that you've done for so many people, and for spending some time with me to answer some questions. So I guess the first question, it's not even really a question. I just want to make a statement. And I know you were very involved with this, but I'm just going to make a statement, and I want you to comment on why this is important. The American Psychiatric Association practice guideline for the psychiatric evaluation of adults recognizes Lyme disease as a medical condition that can cause psychiatric illness and needs to be considered in the assessment of psychiatric patients. Talk about that, and give us a little intro to yourself as well.
Right. Well, I'm a psychiatrist in New Jersey, and I specialize in treating treatment-resistant psychiatric illnesses. And in doing that, I ended up repeatedly encountering many Lyme patients, or patients with infections that resulted in psychiatric symptoms, including Lyme. And it just kept happening. And so I had to be able to to develop more knowledge about it. So I researched it, and I've then treated thousands of patients over quite a few decades. And probably my first patient was back in the early 70s, but at the time I didn't recognize it as a Lyme case. In retrospect, I'm sure it was. But and I've done a number of journal articles, and that's in PubMed and other places on subjects related to Lyme disease. So you had asked about you mentioned about the guidelines. Now, people look at guidelines, and guidelines are not standards. So that can be confused by some people. And this has actually been in the American Psychiatric Association guidelines for a long time. The first edition was 2005. It recognized it then, and it recognized again in the revision in 2016 and expanded some discussion on it. So, and the American Psychiatric Association is 30,000 members. So it's a large organization. And we recognize psychiatric illness. A lot of people don't understand what psychiatric illness is. They think that if there's no physiology, then a psychiatric illness, or those comes from nowheres. But everything's caused by something, and it doesn't. And some people call it psychiatric when they don't know what to call it, and they don't understand it. But what happens is that I think with psychiatric illness, one thing is there's a physiology that occurs and then it evolves into psychiatric symptoms. Now, the average person that I see in my practice, and I did an analysis, is usually 9 years post-infection. So you don't get the psychiatric symptoms a month after. Usually you don't get the psychiatric symptoms a month after infection. Every now and then you see a case progress very rapidly, but usually it may be a latency phase, and then it comes and goes, it waxes and wanes, and comes later on. And it can be a combination of symptoms, and then multiple symptoms. So that's what to look for. And I think, when we look at guidelines, there are other guidelines. ILADS has guidelines. The German Braille Society has guidelines. And there was the IDSA guidelines, and I wrote a journal article questioning the validity of it, and that was published, and that's on PubMed. And particularly in regard to the fact that they did a very poor job addressing the psychiatric symptoms. Now, I keep records of all the psychiatric journal articles that show a connection between Lyme, other tick-borne disease, and psychiatric illness. And right now, there's 529 journal articles in the peer-reviewed literature showing an association, and 89, as I recall, showing an association with dementia. So it's hard to ignore that. And but I think some of the people that try to keep control of how this disease is viewed have little awareness of psychiatry and little understanding of it. So there's a tendency to kind of not recognize it properly. And it's the main cause of death with Lyme disease, suicide.
Yeah.
It's number one cause of death related Lyme disease. And I asked that at different medical groups or meetings. I said, what do you think is the main cause of death related to Lyme disease? And invariably the answer is suicide.
Yeah. Wow. All right. So let's get deep into some of this. Again, the audience for the Love Hope Lyme podcast typically is chronic Lyme survivors. And I saw you speak actually at ILADS. Again, we're doing this interview at the end of 2024, December 2024. And I saw you speak at the ILADS conference in San Antonio in earlier in November, I guess. And, you had a slide where you listed close to 40 symptoms that may appear, from the psychiatric side of Lyme. So we have a lot of listeners who are chronic Lyme survivors who want to know answers, and we have a lot of their friends and family who listen as well. Basic question here, Dr. Bransfield, what, physiologically speaking, happens to the brain from Lyme and the co-infections to cause psychiatric symptoms?
Well, you have to look at it. Most psychiatric symptoms associated with the immune reaction. So you get an infection, and it's often a mixed infection, and we don't totally know all the combination, and you could call it a complex interactive infection. So when you get 1 + 1, when you get multiple infections, 1 + 1 doesn't equal 2, that equals 11. So you have a multiplying effect when you have these multiple pathogens. And there may be other disease drivers, contributors. Then the body reacts, and some of that causes damage to the body, causing dysfunction. But then it also provokes the immune system. An immune system reaction to it is often what causes many of the symptoms that we think of as being associated with the disease. Now you get the early inflammation, and then hopefully you get early inflammation, and then you get later adaptive immunity, and then you're fine. But people don't get adaptive immunity to Lyme disease. They get early inflammation, they don't get adaptive immunity, and they get persistent inflammation, and they might get autoimmunity. And so you're looking at often disease, symptoms associated with either inflammation, autoimmunity, and then that causes a long list of symptoms. Now I do an assessment, and that's available, that's published, and I look at 270 different symptoms that can occur. And of those, my average person that I evaluated, and these are people that were CDC positive, and they were clearly chronic Lyme disease. Nobody could fight and debate and say this wasn't Lyme. And the average person there had 82 symptoms, 82 different symptoms. And my control group, and I had 4 control groups. One control group was medical students, and the average medical student had 4 symptoms compared to 82 with the average Lyme patient. So it's then when you have all those different symptoms, the symptoms interact with each other. So there's what we call disease provocation. When a disease starts, you get a susceptibility, then you get a trigger. And then there's that physiology, disease progression, and disease perpetuation. And then the question is what perpetuates it? And the symptoms sometimes have a lot to do with perpetuating it. For instance, the sleep deprivation. When you invariably get sleep disorders, and then when you're sleep deprived, that magnifies the disease progression. Whereas deep restorative sleep and chronic stress, or sometimes substance use, or many of the symptoms that are caused by this cause the disease progression to occur further. So you have to sort it out, and you could treat it either treating the initial infection or looking at normalizing and helping the functioning immune system, or the third way is looking at symptom control. But those 3 things interact.
Yeah.
And you can't always treat it by what started it. It's like once an avalanche begins, you can't always go backwards. You have to treat the manifestation, downhill manifestation, and sometimes that's the more effective approach.
Yeah. All right. I want to ask you another question that comes up a lot. You kind of briefly touched on this, but I want to get a little more specific. When we talk about the psychiatric side here, or all of the infections, again, almost everybody listening to this knows that it's not just Lyme disease. There's also multiple co-infections. Are they all to blame, or are the neuro issues mainly related to one tick-borne infection specifically? And to be honest with you, when I pose this question to a lot of people, everybody says, oh, it's Bartonella, right? So can you kind of talk a lot about that, or basically not a lot, but kind of address that? Are we talking about Lyme and all the multiple co-infections, or is it really focused on Bartonella? Just kind of give a little clarity.
Well, Bartonella comes up a lot. Relapsing fever, I'm paying more attention to too recently. But when you look at how it affects the brain, it affects the brain 3 different ways.
Yeah.
One is you have immune activation in the body, and that creates these immune transmitters, and then they cross the blood-brain barrier and have an effect on the brain functioning. Second way is a vascular effect, and that may come up somewhat with the Bartonella, but it comes up even with others. So it adversely affects the circulation to the brain. And the third way is when it's actually inside the brain, when it's in the parenchyma of the brain. And that we can see sometimes with autopsies, that we can see spirochetes inside nerve cells. Although that is actually probably the least common. It's more likely the inflammation. So you don't necessarily have infection in the brain. You don't necessarily have neuro-Lyme when you have a lot of the symptoms that we have and a lot of the psychiatric symptoms. More commonly, it's that immune activation in the body that may wax and wane and progress, and you gradually get an expansion of the number of symptoms and the severity of symptoms over time. That's the main, I think, physiology.
I want to talk to you a little bit about depersonalization and derealization in the context of Lyme and co-infections. Is this something related to the bacteria, inflammation, PTSD? I mean, that comes up a lot too. Loss, a lot of people that we talk to in the Lyme world with chronic Lyme, they've lost large parts of their life. So talk a little bit about that if you could.
Depersonalization, as I recall, about 56% of patients have it, and maybe 29 or so of derealization. But what happens, now depersonalization can be a defense mechanism, but it also can be physiologically based. For example, I had a patient who had depersonalization after a brain tumor was removed. So there can a neurological injury. It was a scar from the surgery that caused it. So the neurological dysfunction can cause depersonalization. Another patient, he went over a speed bump and hit the top of his head on the roof of his car. After that, he had derealization. Now, So depersonalization, to describe it, is the opposite would be presence, like command presence or stage presence. You feel like you're there, but you're not there. Like you're a ghost. You're out of touch with yourself. And derealization is your environment doesn't seem real. Now, when it's a defense mechanism, like with PTSD, let's say you're a prisoner of war and you're being tortured, you defend against that by detaching so you're less intact with your current existence. Now, when you have some of these symptoms that are torturous, almost like being a prisoner of war, uh, some people depersonalize, and then the depersonalization, which is the defense mechanism, can be troubling in and of itself. So it can occur on either the neurological basis, or it can be the defense mechanism that might come and go. Either one can occur.
Wow. All right. You mentioned suicide before as being the number one cause of death in the Lyme world. I just want to get your thoughts on this regarding suicidal ideations. And, one of the reasons why I wrote my book, Love, Hope, Lyme, was in I think it was the spring of 2022, in one of the Facebook groups, I saw somebody post, can someone please personal message me on the easiest way to kill myself? The pain is so hard. And a lot of people responded, we're here for you, call me, etc. 5 months later, I saw somebody post, by the way, that person did actually commit suicide with two young children. Talk about that a little bit. Is that a symptom of Lyme? Is it organically caused by the Lyme disease and the co-infections, or is it a result from everything that kind of plays into it? Like we talked about PTSD or other things that might happen in people's lives because of what Lyme does to them
Well, it's a little bit
circumstantially.
like what I said about the depersonalization. Although when you said the children, did they take the two children with them
No,
or?
they didn't know.
Okay, sometimes that occurs.
That's horrible.
That I deal with those cases. So what can happen, I think, two ways. One, first I'll look at it psychologically, the stress of it. And then the second way is looking at the physiology. The physiology can push you that way. So part of it is that you're going about your normal business, and then you come down with Lyme, and you get one more symptom, and it's hard to believe. It's like a nightmare. It affects my cognition, affects my emotion, and my aches and pains, and so you're baffled by the whole thing. You tell your family, and they don't. Well, you look normal. You two arms, two legs. You're walking. You seem okay, and they don't understand it. You go to your family doctor, and they may or may not understand it, and then say, well, I'll go to a specialist. I'll go to an infectious disease doctor, and he'll say, well, you're not two-tier testing positive, so you don't have anything. You don't have Lyme. You definitely don't have Lyme because this test says you don't, which really doesn't say that. They don't understand that a positive test doesn't mean you have it, and a negative test doesn't mean you don't have it.
Yeah.
Most tests, that's what you think, but Lyme testing, it doesn't say that. That isn't the way it is. So then you go to the insurance agency, to try to get coverage, and they say, well, you don't meet the criteria. And then you're having trouble working and you're disabled, and then you get shafted by your disability insurance where they don't want to cover it. And then they say, well, your symptoms are subjective and non-specific. So you don't meet the criteria, and then you feel lost. And it's something isn't right, but you feel lost and frustrated, and everywhere you turn, and you go on some of these government websites and some of these academic, views, and you're not getting answers. So it's frustrating. So that, I think, is one reason that a person feels helpless and hopeless, and then they can feel lost with that, and not just dealing with the illness and dealing with the system that doesn't help you deal with the illness. Okay.
Yeah. Yeah.
Then the other part is the physiology. Now, the physiology is when you get this, and one way to think of it, and this happens with other infections, you see it with malaria, HIV, you see it where when you're in this pro-inflammatory state, it increases an enzyme called IDO. And IDO alters how brain converts tryptophan into what it converts it to. Now, it should convert it to serotonin and melatonin. Those are good things. So when you're in that chronic inflammation state, you instead get a shift towards quinolinic acid, which is a neurotoxin. And quinolinic acid, it can make people suicidal and homicidal. I call it the death formula. And when we do studies and we do autopsies, we can look in the brain of Lyme patients who have committed suicide, and we find quinolinic acid shouldn't be there. So that pushes people that way. There's a physiology that does it. In addition, you get these other symptoms like intrusive symptoms. And the intrusive symptoms that occur, and they're usually in the temporal lobe, but you get these thoughts that come to your head, and they just come, and it's like, where did that come from? And it can be suicidal, it can be homicidal, it can be bizarre. And then you also get depression, and that's one of the most common psych manifestations. And now you have the cognitive impairments where your brain isn't working as well. You have the pain. And then sometimes it gets complicated because people turn to substance use to try to get some immediate relief. And then that can make it worse.
Right.
And one of my most recent journal articles, I addressed that, where someone turned to substance abuse and then it made it worse. And then it contributed to suicide and homicidal behavior and committed suicide. So you have to look at the ripple effect of all those things, and it's perfectly logical. It makes perfect sense. So there's both a psychological and a physiological basis to it.
So a couple of people have asked me to ask you about personality change. I've spoken to a lot of Lyme survivors who have said that when they have had a certain stressor, that their personality completely changed and they didn't even know who they were anymore. And I see this time and time again. Is that a similar answer to the depersonalization and derealization? But I've met people who said their personality on a dime completely
Well, it's
flipped.
another, they may have low frustration tolerance. So they may not be able to, they may have mood swings. They may also have explosive anger. So they are what's sometimes called Lyme rage.
Rage.
And if you've ever seen Lyme rage, you'll never forget it. And I've seen it too many times. It can be quite frightening. And that can be like an explosive quality to it. But there's other ways that it affects personality. There are multiple ways that it can affect personality. So you feel like you're not the person you used to be because you have all these deficits that compromise your functioning, cognitive, emotionally, physically, and it takes a toll on a person.
Yeah. Once again, we're talking today with Dr. Robert Bransfield, talking about the psychiatric aspects of Lyme disease. Dr. Bransfield, you've answered so many questions. I just have two other questions. We polled some people from the audience, from the Facebook world, and asked what they would ask. And we have a couple of them here. You mentioned sleep deprivation before. And I remember when I saw you speak at iLads, you did talk about that a lot. Can you give some solutions? Maybe the best sleep remedy if the sleep cycle is off and there's disruptions?
Well, here's a way to think of it, that when your body heals when you sleep. So let's look at what normal sleep is. Normal sleep is that you fall asleep and you have sleep cycles that are every 90 to 120 minutes. So that's about 4 sleep cycles a night. And your first 2 sleep cycles are what we call delta sleep, slow wave deep sleep. So and that's where your body really heals physiologically. And that's where your immune system would get activated. And that's critical for recovery and healthy immune functioning. Then the next part of your sleep could be the REM sleep, which is more psychologically restorative. And that's like memory reorganization, where things come to your head. That's where you might get nightmares, for example. Now, with Lyme, I've seen all kinds of sleep disorders. You can see sleep apnea, you can see narcolepsy, you can see nightmares, you can see restless leg. You can see where a person, they say, wired and tired and they can't fall asleep. And so then that's a vicious cycle that the illness worsens the quality of the sleep. And then it causes more disease progression. So do whatever may help you to fall sleep better. Now, there's certain meds that sometimes help that we know promote delta sleep, and that's critical. And ironically, most of the meds that are approved for sleep really don't do that. They just help onset and duration, but not quality of sleep, and quality is critical. So it's invariably the psych meds that are approved for other reasons that we give that we know that promote the delta sleep. And then we're also looking, is it more of a delta sleep problem or is it a REM sleep problem? I also see REM behavior disorders where people then act out dreams or sleep paralysis or hypnagogic hallucinations, or there's a long list of things. But you want to, now a lot of people too maybe oversleep, but because their sleep is inefficient, they're making up in quantity what they lack in quality. Also, a lot of people become night owls because they get sensory overload and flooding. And that's a unique symptom where it's like, I can't take all this stimulation in the course of the day. It's just too much.
Right.
It's like too much coming at me. So when I'm alone at night and it's dark and everybody else is asleep, then I can hear myself think and I kind of come alive then. And so then they often have a reversal of sleep wakefulness. They become night owls because there's difficulty tolerating the overstimulation, because the thalamus, the part of the brain, can't gate and filter out stimulation the way it could before they had Lyme disease. So it's usually when I do an assessment with someone, and I'll go through my assessment and like the average 80 symptoms and sometimes more, I'll say, okay, out of all these symptoms, where do we start? It's like a tangled ball of string, and where do you untangle it first? And invariably, the first thing is usually improve the quality of sleep. And then the next question is, well, what prevents you from sleeping? Do you have to get up to urinate, or is it you have reflux, or do you have, restless leg, or do you worry? What is it that prevents you from having not just falling asleep, but staying asleep and not having early morning awakening and having good quality sleep? So that's a way to break it down specifically and look at the details so that you can then go from there.
All right. Once again, we talked today with Dr. Robert Bransfield. We can go in so many other directions here because it's such a complicated side of being a Lyme survivor. I guess I'm going to ask you one final question. I really haven't asked this in a while, but again, my book is called What Family Members, Partners, and Friends Who Love a Chronic Lyme Survivor Need to Know. What do you want to tell those people?
Well, I don't give up hope. And I think it really is, what you have to do is think outside the box for a problem that isn't in the box. And, like there's a quote of, I wouldn't have seen it if I didn't believe it. Okay. A Yogi Berra quote. So I think realize that this is like not something that is, we have in medicine, we use computer medicine, and you go through these algorithms and these drop-down menus, yes, no. And that restricts sometimes how people think and practice. And it's not an emerging disease per se, but it's emerging understanding of something that's been there a very, very long time. And we have to go into it without arrogance. Arrogance is a very bad thing in medicine, and with an open mind, and realize that this is complicated. And if you think inside the box is wrong, that you have to kind of figure out what the box is and go from there. And you have to start, you want to listen carefully to exactly what's going on and try to understand it and go from there, instead of trying to squeeze somebody into a box that's the wrong box. That's what, there's a tendency to do that and say, well, let me do the drop-down menu in a computer and I'll pick the closest thing. And that's what it'll be. So we'll just say you're psychosomatic, and that's wrong. And but you have to get away from that thinking. And I think the people that do best, I think psychiatrists as a group do pretty well because we're trained to listen to patients. And I think a lot of times family doctors, nurse practitioners, people that are close to the patients and put a value in listening and a value in listening and then thinking. It's always a problem when someone has the answer before you finish talking, that they've already categorized and they really aren't thinking about the unique nature of that person's complaints. But I think sometimes the greater difficulty are some people that view themselves as super specialists who think they know everything in that field and their mind is closed and they're not open to kind of understanding something that's really they don't previously understand. So,
Yeah.
and you can tell pretty quickly who's someone who has an open mind, who stops and thinks, versus someone who's dogmatic and rigid, and they just kind of go on some black and white protocol and an inability to weigh shades of gray against each other.
I have one final question. And thanks again, Dr. Bransfield, for being on the show. You've answered a lot of questions that people have brought up to me, and just want to acknowledge you for the amazing work that you've done for so many patients. Uh, we hear a lot about, how someone's been to 5, 10, 20. Dr. Harwood said that he had a patient who went to 100 patients before they got to him. I'm just kind of curious, how many doctors or other types of medical solutions do people go to before they finally get to you?
Well, I had one that went 57. I was number 57, and number 56, unfortunately, was a doctor who recognized Lyme, understood it, but then people went after him
Mm.
and he ended up committing suicide
Oh,
and he
geez.
had Lyme disease.
Ay.
And but one patient said they went to 200 doctors. It's
Mm.
that's um but I think now sometimes you may have to go to different doctors or different treatment approaches to understand different facets of it.
Yeah.
But you want to look at someone who has like a broad picture, who isn't just, we call it silo mentality.
Mm.
And silo mentality is, I'm a psychiatrist, that's all I do. I just look at psychiatry and I don't look at anything else.
Mm.
And I don't look at anything outside that. And some people practice that way.
Yeah. Yeah. So every problem's a nail and every tool's a hammer type of a thing. All right. Once again, Dr. Bransfield, thank you so much. Is there anything else you want to say before we close down?
Well, thank you for doing this. I think it's good. It helps people. Information is power. And it is, I think whether it's Lyme or whatever we call it, and there's a lot of, we see it with COVID, we see it with a lot of conditions. As a psychiatrist, I see three things. On the one hand, see people that have the symptoms from the physiological from it, the stress from it. But the third is I'm often referred because it's like, this doesn't make sense, so they call it that. So they call it psychiatric when it really isn't, when it's a diagnostic problem. Although that's why psychiatrists have to be physicians, because a lot of times we pick up a medical diagnosis that's contributing to something that maybe was overlooked. And it's not just Lyme, it can be many other things.
Yeah.
So it's, I think we got to move forward, and I think we have to work together in a collaborative way. And we have to be careful of these turf struggles where people have dug their heels in. I think it was catastrophic with Lyme disease that the people who originally took command of it and wanted to control it didn't understand it. And they looked at a lot of these symptoms as subjective, non-specific, without making the effort to try to understand it and explain it when it was beyond maybe their ability to explain. And then I think there's certain financial interest, and the testing is off, and then you have all these special interests. So there's a lot of things with politics and money and ego and power and grant money that are a big problem with it. And we have to get through all that and do what's best to help people be healthy and have happy, productive lives.
Absolutely. All right. Once again, this is the Love Hope Lyme podcast. I want to thank Dr. Robert Bransfield for being on today's show. My name is Fred Diamond.